Hi, Duncan Ferguson again. This is the second part of a series of our discussion about managing infections of selected organ system problems in dogs and cats. And we're going to focus on a really important set of organ systems, the urinary tract and reproductive system. These will be extremely important for small animal practitioners, and as a result, this unit's a little bit longer and maybe a little more detailed. As I did in the previous session unit on antimicrobial management of infectious diseases, I want to give first a disclaimer that what we're talking about here are first guess empirical treatments of these organ systems. Culture and sensitivity should always take precedence. Now, with that empirical information, where do you get that? Where do you get the odds to sort of sort this out? And I want to recommend a reference that I've written in here. That is the target reference by David Coyne, and it's being distributed by Bayer as a printed reference, and also it's online and as an app which you can put on your iPad or phone. It's extremely useful. It gives you odds. It gives you recommendations for the bacteria, the antibacterial that can affect certain bacteria that are most likely to affect certain organ systems. And it even includes some estimates of costs or in general categories. So let's start with the urinary tract. The important thing to recognize is that we have to kind of distinguish between the dog and the cat. And on this last point, I'll start with the last point actually. In cats, it's important to recognize that there's an inflammatory cystitis in cats, and you have to distinguish that from infection because the inflammatory form of this cystitis is actually not uncommon at all. Now, moving to the general considerations about the urinary tract, consider when the bladder is infected that the entire region, the kidney, in the case of a male, the prostate and the bladder are also likely to be affected, and this does impact the length of treatment that we have to recommend, sometimes comparing a dog, male versus a female. So it's always recommended to take a look at the urine, try to do a gram stain, or now we have these paddles that you can use to get an estimate of which bacteria are being infecting the area, and it's always useful to get a culture and sensitivity, but we will many times go forward because of cost and simplicity with the best empirical choices for antimicrobial therapy. So who are the actors in urinary tract infection? The vast majority are going to be gram-negative, and these include E. coli, Proteus, Klebsiella, Pseudomonas, and Enterobacter. With the rest being usually some either strep or staph, so that means that those would be the gram-positive you're likely to see. And you'll have mixed infections in about 20% of cases. So you have to keep that in mind, particularly if you look at a gram stain or come back with a urine paddle result that suggests more than one organism. Those paddles, it turns out in recent studies, tend to be less accurate when there's multiple infections involved. In the urine, quantitative determination of bacterial numbers, particularly from a sample collected by cysto or by the catheterized samples, generally should have over 100,000 bacteria per milliliter before you think that it's possibly not a contamination. Anything below that we would call intermediate, and you might have contaminated as you went through the skin or as you passed the catheter. A very nice study was recently published in the AHA journal that went and looked at the bacterial infections from 301 canine and 75 feline E. coli isolates. So let's focus on E. coli because it's the most common bacterium in the urinary tract. And in this study, despite our sort of traditional saying that, you know, you should get a drug that can reach high concentration in the urine, and these would include penicillins and cephalosporins, please note that there was significant resistance against amoxicillin and clavamox in these E. coli samples. And this data was collected in 2005, so we're 9 years after that. And these bacteria are getting smarter. So you can be actually, a big surprise of this study, to me at least, was the significantly lower level of resistance to some what we would call older drugs like trimethoprim-sulfa. And so certainly gentamicin aminoglycosides are going to be very good against E. coli. And of course, in the same category are the cefpodoxime, doxycycline, and enrofloxacin. So when we talk about the empirical choices of treatment of a likely gram-negative infection in the urinary tract, we need to consider those, particularly those at the bottom of the list, and also the information that you might find in Target, which I believe has similar results. So let's take a look at the empirical treatment of urinary tract infections. The first thing to note is that the in vitro culture and sensitivity results, and MIC certainly also leads to 90% treatment success. So in the urinary tract, what you culture and the results that you get are very, very useful to you. Until that point, use the previous information that we talked about from that study in the AHA journal, perhaps, to select a broad spectrum antimicrobial that likely is going to be able to reach high concentrations in the urine and also address gram-negative organisms, unless, of course, you have good evidence from culture and sensitivity or urinary paddle study that suggests that you have gram-positives. And then probably we want to look at trimethoprim-sulfa, the quinolones, cephalosporins, and high doses of aminopenicillins, such as amoxicillin and clavulanic acid. But remember the resistance that we saw in that study. That resistance is going to be regional. It's not going to be necessarily the case where you are or in the population of animals that you have. A lot of it depends on how frequently the drugs like amoxicillin and ampicillin were sort of used from an empirical, even for a prophylactic purposes, because this leads to resistance. Anytime you have an upper UTI problem, kidney, prostate, you really need to reach high concentrations of a drug in the serum and, if possible, in the urine to reach those tissues. So how long do you treat? The standard time frame is 10 to 14 days, but this has come under recent and even earlier than recent consideration with respect to the experience in women with urinary tract infections that have been treated for short periods of time for like 3 days. And a study to reflect on this in dogs of 1988 actually looked at UTIs in dogs, and they basically used once a day, which is probably what we'd use today, only aminoglycoside amikacin or trimethoprim-sulfa for 1 or 3 days. And these results are on the next slide. But the important thing is to note the difference between the male and the female dogs. So here are those results from the Rogers study. Basically, bacteriuria was reduced after single dose treatments, but not eliminated in males. And we can say that the reason for that, as we say later in this, is due to prostatic involvement. They were eliminated in only one female dog given a single dose of amikacin. 3-day treatments, bacteriuria was eliminated in all female dogs with trimethoprim-sulfa, but only in 1 of 4 with amikacin. And note again the importance that because the prostate is a reservoir for bacteria, you really have to treat the prostate to clear disease in the male. A more recent study looking at quinolones in short duration treatment is shown here, and basically there were two groups of animals in this study, and they included one that got enrofloxacin and one that got amoxicillin clavulanic acid. Routine treatment for amoxicillin clavulanic acid for 14 days, and but the Baytril was once a day, which is pretty typical, but only 3 days. And so there were 35 dogs in the first group, 33 in the second. And the thing to note here is there were really no significant differences between the culture results, the microbiological cure rate, nor the clinical cure rate between these two treatments. And so if this suggests that high dose treatment, and notice the dose, very high, 18 to 20 milligrams per kilogram, which you can do in the dog but never do in the cat because of ocular problems that result with doses over 5 milligrams per kilogram in the cat. This is only dogs. Notice the resolution rates are about the same. So how do you monitor success? Basically, you want to follow with urine cultures, and that the first time you might do it is 4 to 7 days after stopping treatment, and then, during treatment, and then this is during, and the 7 to 10 days after therapy is finished. Because recurrence of organisms tend to be fairly rapid. With recurrent UTIs, you have other factors you have to consider. If it's a male, it could be prostate. If it's any animal, it could be a calculus. So think about stones. Think about other factors that could result in. So we have, of course, the prostate in the male and stones in any animal. So those will be nidus of further infection if you don't resolve those by appropriate treatment. So what are recommended empirical drugs for urinary tract infections? I would say that this is going to be a moving target, and pay attention to papers like the one in the AHA journal and look at the target reference for this. But generally it's because we can achieve high concentrations in the urine of aminopenicillins, ampicillin, amoxicillin, or clavamox, or plus or minus with clavulanic, will be good choices for gram-positive infections. So when you have evidence of that, say on a gram stain or a quick test of bacterial infection. With others, gram-negatives, you want to think about trimethoprim-sulfa. Really, nitrofurantoin is more for chronic management. Cephalexin or quinolones. And for recurrent gram-negatives, consider the fluoroquinolones because of the likelihood of Pseudomonas, Proteus, and Klebsiella. And in this case, in dogs, you can go to the higher dosage range, which generally you'll see 10 to 20 milligrams per kilogram. But as I said before, never in cats. So duration of treatment for urinary tract infection, some of these recommendations here are going to be a little bit tainted by or influenced by the study that we told you about of the very short duration, but you want to accomplish sterilization of the urine, and that's the goal. 4 to 6 weeks may be too extensive in current thinking, but particularly for animals that have a prostate infection or a stone with complicating factors, you may need to go this long. After you sterilize the urine, you can often use single evening doses to maintain sterility, or use a urinary antiseptic like nitrofurantoin or trimethoprim-sulfa. The idea is then that the antibacterial resides in the bladder overnight. The animal holds it there, and that's enough to keep the problem under control. Let's focus now on pyelonephritis, or an upper urinary tract infection. Because this is a tissue infection, a very serious one that can lead to very serious consequences for the kidney and can lead to septicemia. You want to have significant period of time, greater than 6 weeks of treatment, and you want to have a drug that gets into the tissue. In this case, we're now thinking of certainly trimethoprim, fluoroquinolones, and maybe even chloramphenicol as one of our drugs of choice for this. Getting a culture from the kidney may be indicated, but usually you're going to go with what you find in the bladder. What about prostatitis in males? Again, the key characteristic that you're looking for of a drug is one that can get into the prostate, so it goes across the blood-prostate barrier. And this is less of an issue during early inflammation. Most drugs will get in during that time, but later on we need a lipid-soluble drug like chloramphenicol, or if you look at the list of, because of the pH changes in the prostate, you can see that many of these drugs will get in. Their weak bases tend to be favored entering. So those are gram-positive are listed for you here, and those where you think or know that there's gram-negative, I've listed for you here. Finally, what about the presence of Pyometra and Endometritis in the intact female? Culture and sensitivity key here. If you get that on the uterine contents. E. coli is their big player because of probably the fecal source. And occasionally you see Proteus and Strep. What do you use? Well, you can use quinolones, trimethoprim-sulfa, and chloramphenicol, again, hitting those gram-negatives. And generally manage the animal systemically. So you want systemic treatment, and intrauterine treatment, infusions, antiseptics, etc., are generally of little value.